Hi all, good afternoon. Thank you so much for having me. As I said, I'm a cardiovascular critical care physician and an emergency physician in Cincinnati, Ohio, in the United States. And for the next 30 minutes or so, I'm just going to share my experiences with what I call subtle shock, and talk a little bit about the complexities of diagnosing shock, which is something that I try to do every day. And I know that all of us have different experiences and we work in different practice environments. And so I would be very interested in a dialogue with all of you about your experiences and what we can do moving forward to have more timely recognition of shock states. So as an overview, we are going to review the definition and types of shock, discuss the recognition of shock states, and then discuss sort of how I try to diagnose the types of different shock states and some of the clinical pearls that I have gathered in my short career. I'd like to start with a summary. So if you only remember a couple of things from my lecture, here's what it is. Shock is a continuum. It's not one type of shock or this type of shock. It's a continuum that requires concomitant diagnosis and management. We're always taught that you can have one shock state or another shock state, but in reality, many times shock states coexist, and it's up to you as the clinician to figure out which ones are at play. There's no substitute for touching your patients, examining your patients, and looking at them and doing a physical exam. Bedside ultrasound, if you have it, can be an incredible tool for helping to rule out or diagnose different types of shock states. And when all else fails, go back to basics and give calcium. So, what is shock? Shock to me is a common final pathway before death. It starts as a reversible process, but quickly can devolve into something that, despite all of our best efforts, can be completely irreversible. And I consider us to be the gatekeeper between the reversible and the irreversible. If we can have timely diagnosis of shock and timely intervention and management, perhaps we can stand between our patients and death. When you talk about types of shock, a lot of us always think about sepsis. At least in the United States, that's something that gets hammered into us every day, that you can't miss septic shock. And you know, when I was in training, I almost thought that was like the only type of shock that you can have, with a couple of notable exceptions of someone in a car accident who was bleeding and clearly had hemorrhagic shock. But there are four main types of shock that we all sort of learn about in medical school: distributive shock, like septic shock, cardiogenic, hypovolemic, and obstructive. And almost every type of shock can kind of be put into one of these categories. And when you're talking about what types of shock present to the emergency department, again, like I said, the majority of us think of sepsis. And in the SOAP-2 trial, which admittedly was a European study, and so that may change depending on kind of your practice environment, but 62% of patients who presented to the emergency department with a shock state were septic. However, 16% were pure cardiogenic shock, which I think is an under-recognized etiology of shock. Hypovolemic shock, 16%, and then obstructive, kind of the probably the most rare type of shock, which we'll get into in a little bit, was 2%. So just remember that when we're talking about different categories of shock, cardiogenic, hypovolemic, and obstructive also exist out there. Distributive shock, again, the most common type of shock, and we all think about sepsis, and we should, because it's a time-sensitive intervention with getting appropriate antibiotics and source control. I also like to talk about something called inflammatory shock, which is not pure sepsis, as you never isolate a pathogen, but this is things like some of what we've seen with COVID, some of the cytokine-mediated inflammatory shock, things you see with pancreatitis, upregulation of cytokine cascades, anaphylaxis, also distributive shock, neurogenic shock, endocrine shock, that's things like adrenal insufficiency or myxedema coma, or even hyperthyroidism. Drug or toxin-induced and liver failure can also cause a profound distributive vasoplegic shock. Cardiogenic shock, and this is what I spend most of my career working on, can usually be categorized into what part of the pump is not working. This is a pure pump problem. And if we're not thinking about what can cause this, we'll probably miss it. Post-myocardial infarction is the #1 cause of cardiogenic shock. Up to 60 to 70% of patients with cardiogenic shock are going to present post-ACS event. But there are plenty of other things that can cause that too. And again, if we're not looking for it, we won't find it. So acute valvular insufficiency, like aortic insufficiency or mitral insufficiency, acute and chronic cardiomyopathy, which includes patients with chronic heart failure. We've also seen this in the COVID population with viral-induced cardiomyopathy, as well as things like giant cell cardiomyopathy. Something that I think is a little bit under-recognized is the role of dynamic LV outflow tract obstruction. So the physiology whereby patients with things like HOCM or systolic anterior mitral valve can have dynamic LV outflow tract obstruction, where the more tachycardic they get, the lower their blood pressure gets. RV failure, however, this is also kind of now a more recognized etiology of cardiogenic shock. But for many years, the RV was kind of the stepsister of the LV. Everybody focused on the LV and ignored the RV. But now we talk a lot about RV failure, from some things like massive pulmonary embolus, acute on chronic RV failure, as we are finding out how many people truly do have chronic pulmonary hypertension in the world. Right-sided MI, so an RCA infarction can cause pure right-sided heart failure. And then other things like a cardiac contusion after a car accident, sepsis-induced cardiomyopathy. This is a great example of how someone can present with two shock states. You can have septic shock, and then on top of this, sepsis-induced cardiomyopathy is a real phenomenon that I think is probably underdiagnosed. And we see up to 50% of patients with sepsis have some degree of profound LV dysfunction. Post-cardiotomy syndrome, so after cardiac surgery, coming off cardiac bypass, many patients will have some degree of cardiac failure. And this is a common thing that I take care of on a regular basis that requires sometimes mechanical circulatory support like ECMO. And arrhythmic cardiogenic shock, so patients who are in AFib for a very long period of time, and they can have a rate-related cardiomyopathy that then can present in cardiogenic shock. And these are all things that I see on a somewhat regular basis, but if you're not thinking about or looking for, you may miss. Hypovolemic, this is a little bit more of the sort of the obvious category. Hemorrhagic shock, hopefully will be non-hemorrhagic shock, something real as well. Poor PO intake, in some of our elderly populations, excessive losses like GI losses or kidney losses or even burns, something that I saw a lot in training because I worked at a burn center. Those patients can present, depending on how far along they are in their course, in pretty profound hypovolemic shock. And finally, obstructive shock. This is everyone's favorite, I think, because most of these things can be fixed with a needle or a drug. Massive pulmonary embolism, tension pneumothorax, pericardial tamponade, and one that I think sometimes doesn't get enough attention is abdominal compartment syndrome. That can be from something like burns, that can be from over-resuscitation in the setting of septic shock, pancreatitis, or it can even be from large ascites can cause abdominal compartment syndrome and require an emergent removal of that fluid. So a couple of pearls then that I would say is we often think about shock in categories, at least in the United States. That's how it's taught in medical school, is that you have those 4 categories of shock and you have to decide which category is the patient in. But I say patients can have as many types of shock as they please, and they often do. Many patients who present at the hospital, in my opinion, have a component of multifactorial shock. And our approach to this must be nuanced and treat these types of shock concomitantly while balancing sometimes competing interests. So we'll talk a little bit about recognition of shock and how I look at vital signs to say, yes, this patient is in shock. So but going completely back to basics, if you look at something as simple as even blood pressure, That can be a real key in the beginning before the patient is hypotensive to show you that they are progressing towards a shock state. If you look at the simple blood pressure, we have a systolic pressure over a diastolic pressure. And we know that the systolic pressure, the squeezing function of the heart, that is proportional to the cardiac output, which is proportional to the heart rate times stroke volume. That's how you calculate cardiac output. And stroke volume, in turn, is proportional to preload, afterload, and contractility. And it's those things right here, the preload, afterload, and contractility, that can be perturbed in many types of shock. We'll talk about that in a second. But if we look here at the diastolic pressure, we know that that's actually proportional to the systemic vascular resistance. Your diastolic pressure is very much related to the tone of your blood vessels, the resting tone. When your heart is in diastole and everything kind of pauses for a second, the pressure that's left behind in the vasculature is proportional to your tone. And that's going to be very important here when we talk about types of shock. So what I would implore you before we get too much into it, and this is what I talk to myself every time in all forms of shock, you must ask, what is the primary problem? There's going to be one primary problem, something that tipped everything on its side and caused an sometimes irreversible cascade of hemodynamic derangements. For every problem, there's a compensatory mechanism that the body is trying to do, whether that is tachycardia or increasing your diastolic pressure. There's some kind of compensatory mechanism that the body is trying to do in order to maintain cardiac output. That's its only goal. The body can be very simple sometimes, maintain cardiac output. So there's a compensatory mechanism to maintain that output. And is it sufficient? Sometimes that compensatory mechanism is sufficient, and it's usually good until it isn't. So going back to looking at our types of cardiogenic shock, we have here cardiac output and systemic vascular resistance up top. Remember, we said again, those are the same things as systolic blood pressure and diastolic blood pressure. So if you look at cardiogenic shock here, you say, what is the primary problem? The primary problem is the pump doesn't work. And so that means your systolic blood pressure is going to be the primary problem. So that's going to be low. What is the compensatory mechanism? You're going to increase your tone. You're going to increase your systemic vascular resistance. So your diastolic will increase. And hypovolemic shock, what's the problem? The problem is going to be preload. You don't have enough fluid. Cardiogenic shock, again, we said, remember, it's going to be all contractility, preload, and afterload. So in cardiogenic shock, the problem is contractility. And hypovolemic shock, the problem is preload. This is the primary problem. Your systolic blood pressure will be low. The compensatory mechanism is to increase your diastolic pressure. And obstructive shock, the problem is afterload. The blood can't get out of the heart due to physical obstruction. So your afterload is high. So that means there's a problem with your systolic blood pressure. What is the compensatory mechanism? Again, your diastolic will try to increase. It's trying to increase the mean arterial pressure. It's trying to perfuse the body. And here in distributive shock, this is the interesting one. What's the problem in distributive shock? It's vascular tone. We know that in things like sepsis, inflammatory shock, anaphylaxis, we have a complete loss of vascular tone. And so here we see that the problem is actually the diastolic blood pressure, and the compensatory response is the systolic blood pressure. And so that is a unique thing in distributive shock that can help us to diagnose this early, is seeing that fall in diastolic blood pressure. You will see the diastolic blood pressure fall far before you actually see that systolic blood pressure fall, because this is the compensatory mechanism. And the patient only becomes quote unquote hypotensive until they can no longer compensate. So again, I said, what is the primary problem? What is the compensatory mechanism? And is it sufficient? And a couple other pearls here. So to remember, all shock pathways, doesn't matter why you have it, they'll end with decreased cardiac output. But some shock pathways can present with increased or even normal cardiac output. All shock pathways end with decreased blood pressure, but some present with a normal blood pressure. And it's up to us to recognize that these patients are in shock. There's no single test to recognize shock. It's a bedside and clinical diagnosis, but you can say that patients will usually have some combination of hemodynamic disturbances, usually hypotension, or a significant change from their baseline. So remember that some patients live incredibly hypertensive, and if they present to the ICU or the emergency department with a quote unquote normal blood pressure, that may actually be relatively hypotensive for them. And usually these patients will have some degree of tachycardia. Something that I use as kind of a quick gut check is something called the shock index. If you haven't heard of it, I think it's a great quick tool to identify people who are at risk of hemodynamic compensation, and it's clinically validated. Basically, it's an index of your heart rate over your systolic blood pressure. Normal for adults is 0.5 to 0.7. So that means if you have a blood pressure of 110 and a heart rate of 90, both are vital signs that you may not necessarily flag in your head as completely abnormal. If you do a shock index on that, that's 0.81. And that has been shown to be linearly inversely related to cardiac index, stroke volume, and your mean arterial pressure. And shock index greater than 1 is associated with significantly poorer outcomes. And even a shock index greater than 0.7 performs just as well as SIRS criteria, which we know sometimes we use to predict elevated lactate and 28-day mortality in the setting of sepsis. If you're worried about, like I said, the diastolic blood pressure, taking too much into effect your blood pressure, you can also use the modified shock index, which uses the MAP instead of a systolic blood pressure. And it also is a strong predictor of mortality. So again, remember, cardiac output is heart rate times stroke volume. Tachycardia is a very easy way to increase cardiac output, and that's why, as I said, most of these patients will have some degree of tachycardia. And it works until it doesn't. And for some patients, tachycardia doesn't work anymore. You have decreased time in diastole, leads to less filling, decreased stroke volume. As I mentioned before, systolic anterior mitral valve physiology, or SAM physiology, where the mitral valve physically obstructs the LV outflow tract. And that being said, I usually say rate is not usually the problem. Usually tachycardia is not the etiology for someone's hemodynamic compromise, and usually it's a compensatory vital sign that I treat as compensatory until proven otherwise. And that means, yes, even AFib with RVR. So unless you can tell me that the patient was hemodynamically stable until they went into AFib with RVR right in front of you, I am very, very cautious to treat AFib with RVR or any other tachydysrhythmia until I have a better understanding of what's going on with the patient, even if they're unstable. So going back to recognizing shock, sometimes people in shock are bradycardic. Even if they have a normal blood pressure, be aware that bradycardia can be very deleterious state if it's how the patient presents, or inappropriate relative bradycardia, which means that if someone is septic and their heart rate is 60, that's actually not good. We would expect them to be working a little bit harder to improve their cardiac output. And if someone's not able to compensate, again, if tachycardia is going to be their compensatory mechanism for shock, it's not sufficient if the patient is relatively bradycardic. Other things to look at, and I know we all know this, low urine output, less than 0.5 cc's per kg per hour. I always tell my residents, yes, it means that patients in shock need a Foley catheter. You have to put it in. That easily rules out obstruction, and it gives you an idea of what the urine output looks like. Finally, perfusion, and this is something that I try to hammer into people I teach on a regular basis, is that you must touch your patients. So many times our patients come to us fully clothed under sheets in beds in situations where we can't see them, and there's really no substitute for feeling patients' arms, legs, and seeing if they're cold or not, especially in cardiogenic shock. This is actually from the hepatology literature here, and this shows different modeling. And you'll never see this if you don't pull the sheets back. And I know that seems so simple, but it's something that sometimes we forget to do, especially in fast-paced busy emergency departments. And this shows how if you don't look, you won't know. Altered mental status, this is something that is very often profound in septic shock, especially, little old ladies with urinary tract infections. In other shock states, it can be a little bit more subtle, very late and less pronounced in cardiogenic shock. It is a harbinger of doom for hemorrhagic shock. If you have a patient in hemorrhagic shock who is altered, that is probably the last thing that'll happen before they have an arrest. I always say agitation is the last neuronal effort before death, and don't take that away from someone unless you're prepared to own their hemodynamics. So the patient that is too agitated for non-invasive ventilation, or they're so agitated you can't get a blood pressure, those are patients that, as tempting as it may be, I try very hard not to sedate. I try to give them no pharmacologic agents, because as soon as you take away the adrenergic drive, they will have profound hemodynamic collapse. Let's talk a little bit about lactate. Everybody loves lactate, and it's built into so many of our pathways and reflexively known that if you think someone is in shock, check a lactate. It's been taught as a mismatch between oxygen delivery and demand, but the truth is lactate's a lot more complicated than that. It's produced in high amounts in normal bodies. It's used as metabolic fuel. The lungs produce lactate, even during septic shock. That's some of Paul Merrick's research. And I think what I try to remember is that lactate is a product of epinephrine-stimulated glycolysis. So you have to have epinephrine to make lactate. And it's an aerobic process. And the more you learn, the more you delve into why lactate is produced when it's produced, the more complicated it gets. And studies have tried and failed to find a clear relationship between lactate and oxygen delivery, as tempting as it is. All treatment options for sepsis that have involved increasing O2 delivery, those have all failed to show any improvement of mortality. And so where does that leave us with lactate? I think that what you can say about lactate is that some patients have a robust catecholaminergic response to stress, and they produce a ton of lactate because epinephrine is produced during their shock state. Epinephrine produces lactate. But some patients do not have this robust response. Those are your elderly, those are your immunosuppressed. And so lactate, I wouldn't ignore it. I say if you see it, that's important. And it may be better at detecting what I call occult shock, is the patient who maybe looks well, but you check a lactate and you're very surprised to see how high it is. But what it really may represent more than anything is a catecholamine-dependent shock state. And trending lactate, unfortunately, has never been shown to improve mortality, even though we do it anyway. It just may show improvement in the stress response and the production of native epinephrine and other catechols rather than an improvement in their perfusion. This is the Andromeda shock trial that came out last year in 2019, where they basically randomized patients in septic shock to lactate versus looking at capillary refill time. And these are patients who went to the ICU, and they resuscitated the patient with fluids or pressors based on either normalizing lactate or normalizing capillary refill time. And they found an 8.5 absolute % risk reduction in 28 mortality in the capillary refill group. So they could not prove that following normalizing lactate actually improved survival. So what I would say about lactate, I think it's an imperfect biomarker for shock. It likely does correlate probably to disease severity, so I would not ignore it. But I think it needs to be incorporated with the overall picture of the patient. And I think a lack of lactic acidosis should not be reassuring in the right clinical scenario. I think you should be concerned as to why the patient is not able to mount a catechol response and make that lactate. So that leads me to one of my last pearls here, which is if you expect to see something and it's not there, you should not be happy, you should be afraid. So if you expect to see a lactate and there's no lactate, ask yourself, why can this patient not produce lactate? If you would expect this patient to be tachycardic or febrile or have an elevated white blood cell count and they can't mount that, you need to ask yourself, where is it and why is this patient not able to mount, again, the appropriate compensatory response? This is another pearl here. Always, always, always correct your anion gap. If you have the ability to measure albumin, you will find elevated anion gaps in patients. If that you didn't know was there, if you correct for albumin, because so many of our patients present to us malnourished. So in the last few minutes here, we'll talk a little bit about how I diagnose shock. I always say, when in doubt, see the patient. A thorough history or chart review, if you have the ability to do so, can identify or exclude a vast majority of the causes of shock. Again, I work in a cardiac ICU, and so I try to look at any kind of cardiac history I have. Also think about immunosuppression, real and functional. I consider poorly controlled diabetics to be functionally immunosuppressed. Think about indwelling devices that could be causing sepsis, including pacemakers. Think about recent procedures, changes to medications, or recent medication noncompliance. Do they have a history of steroid dependence or heavy steroid use? I find that a lot of patients are functionally adrenally insufficient when they present in shock. Again, physical exam, special attention to vital signs as we discussed. They can give you a heads up about distributive shock with that low diastolic before anything else changes. Perfusion, capillary refill, especially in cardiogenic shock. Lethargy, confusion, and altered mental status. And ultrasound. If you have the ability to do bedside ultrasound where you work or practice, I think it's an invaluable tool. I won't go into this too much, but I like the rush exam, which combines a fast exam with aortic views, pulmonary views for tension pneumothorax, and an IVC view to try to look at volume status. And this is something that can help evaluate and rule out a lot of different etiologies of obstructive and hypovolemic shock. And depending on how comfortable you are with cardiac echo, can help aid in the evaluation of cardiogenic shock. Briefly about invasive monitoring devices. Where I work, we use a lot of Swan-Ganz catheters or pulmonary catheters, which used to be back in sort of in the 90s standard of care, at least in the United States, for all forms of shock. They made us put it in everyone. It's fallen out of favor recently. A lot of trials have showed that maybe it doesn't really change mortality and shock. And we don't put these in routinely. However, what I will say is that for patients who have complex cardiogenic shock or where you can't figure out what type of shock they're in, I do find pulmonary catheters to be helpful. My last little topic here is about the mixed venous or SVO2, which in theory, sometimes we say we can use to determine whether patients are in high or low output shock states, which is used with the Fick equation to calculate cardiac output. And I do this every single day in my ICU. Here again is the equation. And remember, in this equation, we're estimating VO2 and we're ignoring dissolved O2. So it's a very imperfect calculation. In most people's practice environment, you're not going to be able to get a pulmonary artery stat. We're getting central line mixed venous, and the studies have shown that can be very clinically different depending on which study you read. So I think probably for SVO2, we can look at trends are probably what matters the most, as numerous factors can affect the SVO2. So that's what I tell my residents and trainees is that one mixed venous stat probably doesn't tell you a ton. Two mixed venous stats probably do tell you a lot. To close out here, some other things that I try to do in shock. Liver function tests are often abnormal and often not ordered in the initial workup of shock. I frequently see pretty profound transaminitis in cardiogenic shock, much more so than in septic shock, until the end. You need albumin to calculate your anion gap anyway. So I would order liver function tests early in a shock picture if you're trying to determine what type of shock you're in. I love checking ionized calcium if you have the resources for that. And I will frequently over resuscitate calcium to add as a natural pressor to increase contractility. I'm a pretty large proponent of steroids in refractory shock states. There's always a lot of debate about getting a random cortisol level to prove adrenal insufficiency. That's fine, but I usually will empirically start steroids anyway. Peripheral pressors are okay, meaning you don't have to have a central line for pressors in the first 24 hours as long as you have a good working peripheral IV and you check it on a regular basis. And so that's fine to start if you have to. And again, finally, perform small tests of change and use dynamic reassessment techniques. So that means giving 500 cc's of fluid and not giving 3 liters of fluid and checking to see if you're making improvement or whether you're flooding the patient's lungs. So in summary, and I know this was a lot in 30 minutes, but remember, shock is a continuum that requires concomitant diagnosis and management. You must do these things together, and that's what makes this so complicating, so challenging, and so rewarding when we can get this right. Shock states coexist. The patient can have as many shock states as they want. They frequently will present with mixed shock states, and you have to use your diagnostic and therapeutic tools to figure out which ones are at play. Touch your patients, feel their legs. You'll identify some occult cardiogenic shock that way. Bedside ultrasound is incredible. If you have it, you can rule in or rule out many types of obstructive and hypovolemic shock with just a simple bedside ultrasound. When all else fails, go back to basics and give calcium. Thank you so much. I'd be happy to answer any questions.